Yeah, I think we can get started with the discussion. So first of all, thank you all for bringing in the concept of care pathways, both in India and in the US. And I guess there are a lot of similarities, but there are also differences and between the geographies. And are there challenges that you can think of if you have to do like an international collaboration, like whether it is in a clinical research setting or if you've heard Dr. Cabra, if you want to take the answer or
Um, as has been discussed by many speakers, collaboration is the key. Like even within the country, and you and uh, Tam very clearly pointed out that collaborations would require sharing of data and all those things, and that is within the country, even within the country and outside the country, would at times would become difficult. But then for collaborations, I think as of now uh, I mean, there are challenges in the sense that primarily for rare diseases, identifying cases, and I think registries in this particular area would really help. And in India, as of now, though the registries have been started, we would not have data for all rare diseases. So, as you will hear in the ICMR registry, we have this registry for a select group of disorders, primarily the ones for which some treatment is available. So number of patients, and then we really need to know all the details which are required for the collaboration, say for clinical trials or anything. But then, and obviously for these collaborations, funding is another issue which may be a problem. But then, if there's a collaborative effort and from both sides there's funding, or even for clinical trials, funding is available through the companies which are conducting these trials, could be okay. But then there are some challenges. But I think that if we all work together and try to create the environment for collaboration by sharing information and sharing data which we have, we can sort of build collaborations and identify areas where research can be done together.
Yep. Thank you, Dr. Cabra. Yep, you have to deal.
Yeah, just I wanted to add. No? Oh, sorry. So I just wanted to add one thing. Data sharing can come in different varieties, right? You can think about anonymized clinical data that is being shared, but at the same time, sharing of anonymized genetic data is also rather important. And towards that, NIH has a wonderful platform called ClinVar. And I'm very happy to say we are one of the topmost submitters. Our institute is one of the topmost submitters from India on the ClinVar database. And through that, actually, sometimes we get queries from the US saying, hey, look, we have also found a patient with this variant. Does your phenotype match with what we have? And that really helps in getting diagnosis, not just for our patient, but for another patient as well.
And Dr. Gupta?
Yeah, Reena. So there are definitely opportunities, and we have tried some of the international collaborations, and sometimes it is limited by the rules and regulations. I'll give you an example here. So for our ALD National Registry, actually, our plan was not to keep it national. Actually, we wanted to do more of an international registry. What limited it to go international was the rules around the biobanking, and it was interesting to know that you can enroll patients remotely on an online platform, but if you have to ship the biospecimens, there are certain rules and there are certain custom issues that you have to like be aware of across the country. So it can be done, but there is a lot of policy and paperwork behind it, especially if you want to share some of the biospecimen data. I think this is one of the blessings of COVID, unfortunately, that we had to go all that way to get this blessing. That there is a lot of collaboration now happening in the e-space, actually. Like so, on the cloud platforms, there is sharing of anonymized data. There are these registries actually that you can build on the cloud, where like people can upload even the scans and the labs actually that is done in any part of the world. So I think it is just we have to be innovative in identifying these platforms and designing the studies in which it has to be useful for all the collaborators. So again, I go back to my model of stakeholders, where unless and until it is benefiting all the collaborators, it is difficult to do research. And again, because as Dr. Kabra mentioned, there is a cost associated to this. There is a time that researchers put into this. So it has to be a model which is benefiting community and the researchers and overall progressing the advances in the diseases.
Thank you. Did you have anything to add?
No, I think everyone's covered everything.
Okay. Harsha, is there a question online?
Yes, there is a question for Dr. Kabra from Anita Santosh, requesting you to speak about carrier screening of females.
Okay, so if I understand the question correctly, are you talking about carrier screening of females only, or you are talking about say families where you are suspecting a X-linked disorder and then you want to screen females for being carrier or no? So if that clarification is given, then otherwise, if you are talking of screening in general, I mean, even in low risk population, for primarily that is being done for recessive disorders to find out the carrier status. But some of the carrier screening for X-linked disorders, particularly for Fragile X syndrome and also for DMD, some of the couples come to us for screening for that targetedly, and so that is there. But if you have any targeted question in this, if you can tell some more details, I can answer.
Thank you. Is there another question there?
Yes, hi. Before I ask my question, I just wanted to say hi to Dr. Gupta. This is Ginger. I am here, and I will see you next month at ASH. I wanted to ask, how do we impress upon HRA in all of its agencies that we can't keep talking about newborn screening and identifying children at birth and subsequently members of their family and not have genetic counseling, because that is missing. You have 700 geneticists providing counseling in this country. Funding was cut last year, and we work with NIMAC, New York Mid-Atlantic and Caribbean Genetics Alliance. We went to the Virgin Islands to talk about doing telegenetics because they don't have a geneticist, and it's pretty much the same way across the country. One person may be in the state, maybe none. How do we impress upon the government that genetic counseling needs to be funded? Because we have young people who have trait, who have no idea because the history didn't follow them, and they did not get age-appropriate counseling, you know, between being a child, being a teenager, and then again as a young adult. Again, you need to know that you carry a trait for this order. You need to know that you're going to ask the person that you plan to have a relationship with and maybe have children with to find out if they carry a gene, and for them to also get genetic counseling to understand it from your perspective, you know. So what do we do here?
That's a tough one. Up till March, that was my life. So at the Children's Hospital in Washington, D.C., as the geneticist, we would get all the phone calls for every newborn screen for biochemical genetics from D.C., Maryland, Virginia, West Virginia, as well as Delaware. So we see all of this. Now, from a genetic standpoint, so we never saw sickle cell patients, all right? That went to hematology. But from our standpoint, we did provide genetic counseling in the form of the geneticist, because they wouldn't spend money to pay the genetic counselors. So as part of our job, we would have to do genetic counseling. And one protocol that we formed was we would bring the patients back, or the families back, a year and a half later, even though they were just, you know, carriers, so that we could talk to them and reiterate the fact that when they got older, they needed to be seen, when, you know, to understand what was going on with them. Again, we're a very overworked workforce, you know, so sometimes people fall through the cracks. Now, asking regulators or asking insurance companies to pay for genetic counseling, when you find the formula, you let me know, because we'll be very rich after that.
Is there anything to add, Ashish?
Yeah, thank you, Ginger, for raising this issue. I'll just make a statement that we are really just scratching the surface of issues in sickle cell. The disease has been there for centuries, but we are just starting to scratch these real issues, right? We are at the tip of iceberg, right? We are talking about treatment, we are talking about curative options, but there are a lot more issues in sickle cell, as we all know. Actually, I was 2 weeks ago. I was in a APHL symposium where there was a very interesting study that was presented by the group at UAB. Najiba presented this study called Enhance One, actually, where they looked into the newborn screening for sickle cell and how many of those kids eventually make it to the clinic. And we are talking about a US setup here. And more than 40% of the kids, and these are like heavily dense state actually for sickle cell, they do not reach the hematologist in the first 3 months of their diagnosis. So you're talking about a system where we all are very strongly like subspecialist heavy, and we want to make sure that these kids are in the proper care. It is not happening. It is not happening at a lot of different levels, and genetic counseling is such an important piece. One of the goals actually of my presentation was to bring two diseases where there are two different disease models actually per se, both undergoing newborn screening in the US, where XALD actually it's a different model where we have taken a like a bottom up approach. I don't know if it is right to say up there, but it is more of integrating that into a medical home versus sickle cell, where we as transplanters are put into the tertiary zone, which doesn't need to be. Like, we can definitely be more involved and integrate this care model where we are interacting with the community. But there are several different components here. And you brought up a very important stakeholder. Like, this kind of like applies to ALD as well as sickle cell. But yep, there are big deficiencies out there. And again, we are scratching the surface right now.
Even the trait.
Yes, absolutely. If you have to really cure the disease, you have to make that effect at the trait level. It is not going to be just those who are identified by sickle cell disease per se. Like, there is definitely a big role of patients who need to be counseled who have sickle cell trait. And as you know, there are issues, there are some medical complications that can happen in patients with sickle cell trait as compared to disease. So all that needs to be identified.
There's another question here.
Yes, hi there, Dean Sir with MLD Foundation. Tam, you really hit my button a few times. I just wanted to, you talked about a lot of the numbers and the things that we don't understand. The Every Life Foundation, who has a booth out here today, they've just been set up. They've done a burden of care study. This is the second generation of that. I just want to refer people to that. So much of our legislation and the support that we're after requires numbers to justify. What are the expenses? What are the direct expenses, the indirect expenses? This second generation of their report, which I think is from this last summer, the original report was about 3 years ago, talks about the cost of delayed diagnosis. So if we wait to get a diagnosis, then we're adding additional burden to the system, and it's an ongoing burden. So I encourage you to pick up a copy of that.
Thank you for that. And I have a question for you, Harsh. So it's a very good low-cost technology, but do you have a plan for making it global? I know you're testing it out in the UK systems, but bringing it to the US, is that a possibility? Or
Yes, actually, there's one thing I left out of that. So in the US, there is a heavy dominance, if correct me if I'm wrong, is towards having dry blood spots for getting samples from the patient rather than taking blood in EDTA vials. So all the stuff that I showed was from DNA that was extracted from EDTA vials. But just a little over a month ago, we started working with dried blood spots, because when you get DNA out of those, it's very fragmented. It's not of the highest quality. But I'm very happy to tell you that my PhD student, just before I left, did manage to crack the code. And we have just started working on that. We'll be analyzing a further 100 samples on dried blood spots to be absolutely sure that the assay is behaving the way we expect it to behave, regardless of the sample type. And that would allow us to crack into the American market. And hopefully next time, if we really do crack, then I can fly in a helicopter out here.
thank you for that. And another question to Dr. Cabra. I mean, I think the care pathways, one of the striking difference I noticed between research and the care pathways in the US is the inclusion of patient advocacy groups. I know there are not such organized, I mean, there are few groups, but not as extensive in the US as in the US. But even with those few, I don't know how much they are being involved in decisions around what does it matter to you? What is it that we are trying to measure as an outcome? measure and things like that. Do you have any comments on that?
Yeah, so Reena, what is happening is that there are many parent groups which are there, and as I said that even the declaration of rare disease policy and many of the decisions which government has taken were actually because of the advocacy which was done by these parent groups. So it is important, and I was saying that their role is actually not really well defined as of now, and their involvement in decision making, if we are saying that decision making for say implementation of RD policy, or when the rare disease policy was being prepared, there were as such, I don't think that there were any representatives from the parent groups. But then having said that, the policy was put on the web for taking opinions, and I know that many of the rare disease groups actually they gave their opinion on this, and some modifications are probably done based on that. But now what is happening is that when it has now come to funding treatment, particularly for diseases where the cost is very high, there are discussions now. There is a National Rare Disease Committee now, a 5-membered committee, and in fact the court has asked this committee to interact with the parent groups also, because many decisions are pending and decisions are to be taken. There are efforts to I mean, you know that a 50 lakh thing, which is $60,000 of few diseases, can be treated for a longish time, and many diseases cannot be treated. So now the parent groups are on board, and the government is also talking to them. It was there earlier also, but not in a very formal or a regular way. But then now they're on board. And I totally agree that they have to be involved when decision making is being done for rare diseases.
And how about for research? Do you collaborate with patient groups?
So, what happened was, when this rare disease registry was being planned by the ICMR, there was a suggestion, and in fact, many of the groups like the hemophilia group, thalassemia group, the LSD group, they also volunteered that probably this registry can contribute patients to this registry. But as of now, they are not contributing directly to the registry, but then through some of the institutions who are linked with these groups are getting patients from there, and they are getting into the registry. So individually, they are not contributing. And as far as the research is concerned, if you're talking of core research, their involvement as of now is not as much. Even in clinical trials, we do contact these support groups if we are seeking for patients for clinical trials, and a word goes around, and they tell the patients that they can visit these hospitals, and if the inclusion criteria are met, then patients can be enrolled. But active involvement in planning research is not there as of now.
I think we'll close soon. Maybe any last thoughts or any last words? I'll start with Dr. Gupta.
Thank you, Reena, and Harsha, for putting this session together. It was very helpful, and I look forward to many collaborations out of this. If there are any other questions for me, please feel free to share my contact information. I'll be happy to address them.
Sure. Yep. Dr. Kabra.
So a really nice session, a lot of good interaction. I learned many new things. And as far as collaboration is concerned, I really look forward, and I would like to tell Dr. Gupta that we are actively working on the HSCT for patients with lysosomal storage disorders, adrenoleukodystrophy. We have done a few in our department also, and we think that for many disorders where HSCT has not been explored, or there are very few cases all over the world, maybe in a setting like ours with resource limited settings, if we can have a good program for HSCT for many of the disorders where it is not very well explored, I think it would be a good idea, and we would be really happy to collaborate with you in this direction. Thank you.
Absolutely. Yeah, we'll be happy to.
Considering that Indians make up one of the largest diaspora in the US, and other European countries. I think this forum is very, very timely. So a huge kudos to Dr. Harsha, Dr. Reena for organizing this. And I hope that this platform helps the patient support groups, the families, scientists and academics and clinicians come together and actually make something very, very fruitful along with government regulatory bodies and take it forward. So thank you all.
Well, I'd just like to say thank you very much for having me here today. I've really enjoyed it. The one thing I think we have a lot of people in the audience here today, people in academia, people in the advocacy groups, people who have nonprofit organizations. Maybe collectively we could work together and form some sort of committee to talk to regulators, and say, hey, this has been going on for a really long time right now. We've got countries that we need to go to. This is not a community issue anymore. It's a global issue. And maybe get together and work something out and try to hopefully get some answers at some point.
Thank
Yeah.
you. And I would add that I guess this is a good start for such international collaborations. And we do have platforms, the patient concierge platform, where physicians could refer the patients or patients find us actually, and they can connect with international experts, researchers, and same thing with researchers. And we do have a research core, which is just a group of experts, physicians, researchers who are there to offer that second opinion or the expert opinion to the patients' families, or maybe to the physician themselves, or a genetic counselor. And so check us out. And I mean, this is a beginning, and hopefully there will be more collaborations. And I would like to thank all panelists for joining us, and thank you all for staying. So we will have a short break because we are running really late with thanks to the fire alarm. So we will come back within 5 minutes. And actually the poster session is open. Like if you have posters, you can put it up and Nisha can let you know where the place is. Okay. Thank you all.
Thank you.
This will be a very quick break. Please get back into the room within 5 minutes if you can.